everybody for joining us. And thank you so much, Michael, for presenting. And just a reminder, we are recording this and we will distribute this so that you have access to this material at a future date. Again, feel free to ask questions. You can submit it in the chat box. We'll make sure there's plenty of time for Q&A. And do make sure that your lines are muted just to not disrupt the presentation. And with that, Michael, thank
Thank
you.
you, Jenna. My name is Michael Goldsmith with Behavioral Care Solutions. Today, we're going to take the previously discussed regulations a little bit further and explore some of the potential interventions or what we can do to maintain aspects of compliance. And now, before jumping fully into that, I want to give a quick recap of the regulations themselves, just to plant that seed of thought of really what we're looking at and what we're planning around. Now, before we do that, some statistics I know Anthony Bunyan highlighted in the previous interaction, the previous webinar, the idea that approximately 1% of our population is diagnosed with schizophrenia or some form of schizophrenia. But in long-term care, when you do a 5-year look back, in some areas we're seeing 20% of the population having that diagnosis. Now, there may be some correlation to individuals who are challenged with schizophrenia having a higher utilization rate of healthcare systems, which could account for some of those, but going from 1% to 20% is quite significant. Now, when we open up the statistics beyond schizophrenia itself, what we find is between 60 and 90% of individuals in long-term care are diagnosed and classified with a significant mental illness, and those mental illnesses quite often require the utilization of psychotropic medications. Now, with that in mind, that 60 to 90%, what we see is now individuals who are diagnosed with a chronic or significant mental illness outnumber admission-wise individuals diagnosed with dementia coming into long-term care. And to further complicate that, the studies show individuals who admit for short-term care rehab with the goal of returning home, the individuals with a severe, significant mental illness are 45.5% more likely to transition to long-term care. And when you play that out over several years, what we end up with is a younger, more chronically ill population, which changes our approach, and it requires us to change our perception of the utilization of not only medications, but non-pharmacological interventions. So when we do a recap of what Anthony covered in quite a bit of depth, is that first piece is the chemical restraint, that F605. And what we find in there is a handful of criteria or categories being reviewed, and we saw some adjustment in the regulation. So we see the chemical restraint component in a big frame around the utilization, the lack of utilization where we shouldn't, to use it for convenience or discipline. And I'm going to explore that further down the road here. The need for a comprehensive assessment and purpose-driven behavioral health assessments and interventions. Determining the necessity of a psychotropic medication. Also, the resident's right to be informed. That's that informed consent when a medication is initiated, increased or decreased, that gradual dose reduction, and which is mentioned down below there. But also the documentation of dose, duration, and then our need to inspect what we expect, the monitoring of adverse consequences, and recognizing that those can exist. Now, I wanted to put the definitions that were identified for convenience and discipline as a whole. So convenience, it's defined as the result of any action, not just medications, that has the effect of altering a resident's behavior such that the resident requires a lesser amount of effort or care, and it's not in the resident's best interest. Now, I put that out there because I strongly believe that it opens the door to a discretionary piece on the end of a surveyor of how do they perceive it. And then it's up to us to create that framework or narrative around the use of the medication or the intervention and the purpose. Now, discipline, any action taken by a facility staff for the purpose of punishment or penalizing an individual. I did throw in indication of use. I'm going to talk about that a little bit more down the road as well, but it's defined as the identified documented clinical rationale for the utilization of a medication or for the intervention itself. Now, when we talk about convenience, what are they looking for? It's if they see that a medication results in neurovegetative presentation, so increased lethargy, a tendency to sleep, or functional limitation, if that exists within an individual or their presentation, it falls on us and it falls on your staff to create the documentation, the narrative showing why that presents. Is it a disease process progression? Is it related to perhaps a medication or a treatment like chemotherapy, things where we would expect some of that to be present, but really show that it's not in relation to the utilization of a psychotropic medication if we are doing that. Some of the other things they're going to look at: loss of autonomy, maybe a change in that mental status or a change in activity engagement, skin integrity or continence levels, and just a functional decline psychologically or physically. We need to document around that and account for those changes in a way that shows that it's not due to the utilization of psychotropic medications. Now, comprehensive care plans. This is where we're looking at the diagnostic piece of it, especially schizophrenia. Schizophrenia is one of the things mentioned in the regulations, and we need to make sure we're using evidence-based criteria for diagnosis and showing the path to diagnosis of somebody admitted to the best of our ability. And when we look at evidence-based criteria, we also have to look at what surveyors, what the monitors will be looking at as far as insufficient documentation. On our end, on facility end, we need to document in a way that indicates that the resident has had symptoms, aspect of disturbance, and behaviors consistent with the DSM criteria. Now, the DSM is the Diagnostic Statistics Manual that lays out clinical criteria for specific mental health disorders. Right? We need to document around the diagnosis being given, and that we have to show it was based on a comprehensive assessment. So that purpose-driven behavioral health assessment that identifies the criteria and history that supports the diagnosis. Within all of that, we have to show that there was a rule out. It's not related to the start of a medication, or perhaps a progressing disease process or alternate presentation that could cause delirium. And then we have to document the effect of the disturbance has on the resident in that it creates a functional impairment. And that's a big thing with a lot of diagnostics when we look at the DSM or mental health diagnosis piece of it is if there's not a functional impairment, the person does not meet criteria. So we have to identify that. And all of these components must be within the documentation. If not, it is seen as insufficient documentation. Now, the accuracy of assessment and coordination. We really want to look at this to make sure that there is sufficient documentation to support the diagnosis within the MDS, especially for individuals receiving the antipsychotic medications, right? And some of the language within the regulation directs the monitors to make a referral to the OIG or to the licensing board within that state if they find 3 or more individuals with what they have determined as inaccurate diagnosis. Right, so the person just does not meet the clinical criteria for the diagnosis listed, or it's a diagnosis that quite rarely will present later in life. Schizophrenia is a great example of that. Rarely do we see any diagnostic presentation beyond the age of 40. And even at 38 to 40, it's quite rare. The start of all of this, when we talk about the what we can do, it's the identification of our interdisciplinary team. We have these individuals on our team for a reason, and we all bring different strengths to the table. And it's up to us then to leverage those resources and strengths when we're creating that plan of care for the folks that we serve. So together as a team, we want to make sure we're including everybody involved in the care of that individual. We want to establish goals, mutually agreed upon goals, and timelines for those goals to be met. And we can do so through the integration and utilization of behavior management meetings. Sometimes those meetings are held monthly, quarterly, and I have some homes that they're held even weekly, where individuals are brought to the table, so to speak, and they really dig into the core and essence of who that person is and what they're presenting with from a behavioral or mood perspective, and how do we navigate that. Talking about the antipsychotics, because we mentioned it a few slides ago, we need to be mindful of just the diagnosis that justify their utilization. Now, I want to note too that some of these diagnoses deviate from what are listed for the 5-star quality rating initiative, but are FDA approved as far as the utilization of antipsychotics. So you have the schizophrenia codes, paraphrenia, shared psychotic disorders, depression with psychosis. And in that case, even though it's a mood disorder, if psychosis is present, we can justify the utilization of antipsychotics, but they're going to be short term. When we find resolution of that psychosis, we start the GDR process and get rid of that medication. So just be mindful of what's being listed as far as the reason for the utilization. On our end, and what we recommend as well, is integrating a schizophrenia audit where you look at each individual, what the diagnosis is, and then what was the path leading to that diagnosis? Were they diagnosed early in life, upon admission to the facility, or was there some sort of outlier event midlife? And then is it appropriate? This all falls within that realm of having and developing a behavior program within your skilled nursing facility or assisted living, whatever it might be. And this is going to be different for each individual, each facility, based on the demographic and the culture that you serve. But we want to make sure it goes back to that IDT. You know, IDT should lead the program, the initiative, play an active and fluid role. And then again, what are our goals? Coordination of care. Who are we integrating from a resource perspective, and are we leveraging the resources available to the fullest extent possible? What are we doing for documentation and how does it look? How can we enhance that documentation again to support the narrative that led us to the utilization of interventions, whether it's psychotropic medications or non-pharmacological interventions? Behavior tracking, having that behavior management committee engaging in active GDR considerations. And we use considerations because sometimes it's not appropriate. It's contraindicated to engage in a gradual dose reduction based on a person's history or current presentation. We certainly don't want to take away a medication or decrease a medication when somebody's actively experiencing symptoms or decompensation. Staff and family training, I think, are huge. We can arm our staff to navigate some of these things in a non-pharmacological way that allows us to better decrease the utilization of psychotropic medications. And providing family education to a major extent gets their buy-in. They can be part of the intervention program, but it also helps when it comes time to have the discussion that a medication change is recommended. And then activities as well. Rec therapy is a beautiful thing. I can't recommend it enough. I'm even going to talk on it a little bit down the road here. Some of the basics to tracking behaviors. We want a good assessment, whether that comes from the med staff in the facility social worker, or contractors, like myself as a clinical social worker and therapist, or Anthony Bunin, a nurse practitioner who specializes in psychiatry. Looking at diagnosis or determining the appropriate diagnosis, and if a diagnosis just doesn't fit, what's the cause? What's the trigger? Then developing a plan around treatment and management that is a team decision. And our teams get educated on how are we going to do this? What are those interventions? Then monitor response. And again, I always like to highlight without behavior tracking and associated documentation, we just simply don't have the justification to use medications or implement specific interventions. Some of the simple tools, when we look at behavior tracking, it's going to go in two different directions as far as process or type. There's going to be frequency and functionality. We're talking frequency, it's just how often and when does this occur? From a functional analysis, it digs a little bit deeper, looking at triggers and contributing factors, and then the consequences post a behavior. What happens? When I look at that, and the way I actually train a lot of staff in our homes is with the ABC model. And the ABC is the antecedent, the behavior, and the consequence. And we can train staff not only to observe behaviors in this way, but to document in the same way. So an antecedent is the trigger. What preceded the behavior? What set the individual off? And then the behavior itself is that response to the trigger. And we try to focus on just one response at a time because some of our folks will present with multiple behaviors. That's the reality of it. But we want to break that down and develop a plan around each behavior. And then what's the consequence? Post the behavior. And this could be the individual themselves feels an aspect of shame or lacking interpersonal relationship, or it could be responses from maybe our staff, other residents, family members, visitors, just other individuals. So we dig into that. I I encourage taking this a little bit further beyond just the antecedent, the behavior, and the consequence. I like to integrate de-escalation and decide debrief. De-escalation is where our staff get involved. Sometimes it's with some immediacy as well, where they de-escalate. When I think de-escalate, I think about dysregulation to co-regulation. Now, co-regulation is something, again, we can teach our staff to do in the moment. And that's where our staff present with a calm, composed demeanor. They're mindful of the tone and volume of their voice, the rate of speech. And the whole goal is to create a calm and pleasant presence. And with that, the resident will usually follow our nonverbals, our rate of speech, and de-escalate or re-regulate with us. Once all of that's done and we're back to baseline, we want to decide and debrief. We have a team discussion of what changes can we make? What can we do within the environment, or how can our staff better intervene in moments that a trigger is noticed? And the goal is to either eliminate the trigger or minimize the behavioral response when a trigger is present. So this falls into that care planning category, but could also be brought to a behavior management meeting and discussed at more length. I'm a visual person. I wanted to create a visual, so I put this together so folks can see it. Feel free to take it, run with it, utilize it, but it highlights at the top of that cycle the activating event that results in a behavior. And then ultimately, there's a consequence. After the consequence, once that person's de-escalated and maybe the situation's resolved, we engage in that debriefing process, that planning process. It's almost a decision tree, but this is how I like to see things visually of how I'd approach a behavior, what I would do with a team to help navigate that behavior. Now, as I mentioned, sometimes when we get to that de-escalate piece, we're going to have to train our staff and teach our staff how to have immediate intervention. And sometimes it's removing other residents from danger, remove potential weapons. And weapons, of course, it would be like a red flag type statement or word, but I mean forks, spoons, trays they can throw, remote controls, which we've all seen those come out of a room and fly into the hall before. Right? Or spatial interventions. If I know somebody's not going to respond well to me being very close to them, I'm going to start my conversation 5 to 6 feet away. And I'm going to engage that individual. And that spatial intervention can be on the care plan as a non-pharmacological intervention utilized when patient A or John Doe escalates. We also want to make sure that we're communicating in a calm, non-confrontational way, a neutral way, right? It goes back to that co-regulation. And I like to remind staff that communication is 55% body language, 38% tone of our voice, only 7% the words we actually speak. So it's how do we create that presence in that environment? And the words are the last thing we consider. It's how we say them, right? And how we present physically. Want to encourage individuals to talk about their feelings so that that frustration doesn't build into a negative behavior. Empathize with them. I can see that you're upset. Can I help? Right? Or angry or frightened or whatever it might be. Allow the opportunity for a person to express themselves. Act as a sounding board.
I,
Try. Oh, is that a question or someone talking?
that's okay.
Yeah, perfect. All right. Engage medical staff for coordination of care. That's why they're there. Right? If there's a new
Okay.
symptom, we have to ask the why. Right? New pain? Is it a fracture? Are they post-surgery? Could there be something in there causing a delirium? Or an exacerbation of an old symptom, a disease process, COPD, or some of the thyroid diseases can cause depression and linked to psychosis. Right? Hypoxia can present just like anxiety, or at what we call the happy hypoxic, the individual who's a little bit escalated and you wouldn't really know that the hypoxia is there. Or is it a medication? Did we start something new? Or has something else been integrated? And that could be the antidepressants that are integrated to help with the presentation, but only make it worse. Now, staff and family education. I'm a huge proponent of this because I think it can go a long ways, especially with our staff. But I think we have to remember that family play a pivotal role as well, even if they're not there every day. They can be additional support. So we want to provide that education to our staff. We want to arm them with the tools to navigate some of these complexities, but also support family members in this difficult time as well. It's hard to have somebody go through a dementia process or to be chronically mentally ill or have a disease process that is irreversible. I often find too that if we provide progressive education with family, they're much more receptive to the integration of gradual dose reductions or changes in care. An example of that, I've recently in our Upper Peninsula, we partner with a home for veterans. I went up and we provided a family education evening where we provided food and we had a broad discussion and presentation about dementia, the progression, various mental illnesses, and what the current research is. And we really armed family members with the tools to understand the behaviors their loved ones presenting with. And when you do that, they're much more receptive to staff interventions that before they may not have just understood, may not have understood and been a little bit resistant to. Now, we need to make effort, or at least show effort, that we are tracking medications, that we're considering those gradual dose reductions. And I always go back to the considering gradual dose reductions because, again, sometimes they're contraindicated and it's not in the patient's best interest to do them. The picture here is an example of what we use within behavioral care solutions. It can be emulated any place, but it shows if a person's on a particular medication, we track the date that we considered it. We put in documentation related to the why we did go with it or the why we did not. A lot of this is done during the behavior management meetings as well. So there's IDT input with all of it. We want to enhance our efforts for the care coordination. Again, behavior management meetings go a long ways and a lot can be done there. This is an example of a sheet that's actually a PDF now that is utilized during the meetings. Again, it doesn't have to look like this, but it can be modeled a little bit. I think this has actually been formatted for PCC now and utilized in like a UDA, but it highlights who was present, when it was reviewed, what was reviewed, and then what the decision was. Right? And then we can show now that narrative, that process of consideration, and what we've done and have not done, and for what reason. Right? We're really looking for that justification piece. Now, some of the non-pharmacological interventions, these now, and they should have been before too, need to be utilized before the consideration of alternate, more intrusive interventions like medications. Right? So some of the things we want to look at, it's not just the availability of activities, but are they dignified and appropriate for the population that we serve? We need to show staff training, not just on dementia care, but mental health and non-pharmacological pieces. What environmental modifications can we integrate? We can look at lighting, music, the color of walls, pictures, have the Schnauzlin rooms and things like that, sensory rooms, which I know some of my facilities have, and they go a long way as far as intervention. What access to behavioral health services are there? Again, look at the community that you reside in. And I also recognize that some communities are resource rich and some are resource deficient. And then we get creative of how we navigate some of that stuff. Resource deficient communities, we look at technology, utilize video, kind of like what we're doing right now. We get creative of how do we get these services in front of folks. Use family-based interventions and then individualized behavior management. And I know since the career started, right? Your career started, we've talked about person-centered care planning. What that really means is digging deep and recognizing the core and essence of who a person is, what history they're bringing to the table, what tools do they already possess, and then what can we do to build upon the tools that they have. So it's going from I guess the best way to describe it, because I don't have a slide in here for it, it's going from pathogenesis to salutogenic. Pathology is diagnosis. Identify the diagnosis, integrate treatment, resolve the disease. Where a salutogenic approach is still the recognition that a disease could exist, but it looks at, again, the core and essence of who a person is, what resources they have available, supports, community aspects of how can we create health, the best quality of life possible, leveraging every resource we have for an individual. So I promote the salutogenic approach much more than the pathogenic approach because we see more positive outcomes, but it does take a team approach to do so. But why not just give a pill? We need to have that discussion because a lot of medications truly are effective and they are appropriate in some situations to create not only quality of life, but safety for an individual as well. We also have to, on the other end of that, recognize that some medications just have very limited benefit. An example is antipsychotic use with dementia type patients. We could even look at antidepressants, right? A year or two ago, a study came out and showed that serotonin really doesn't have much to do with depression, but the vast majority of antidepressants are selective serotonin reuptake inhibitors. So it caused us to take a deep dive and look at, are these truly effective? And why are we using these medications? And the medications don't really work for individuals who wander and pace, might be restless and fidgety. Poor self-care, which is that hygiene piece. Disrobing, right? Disrobing is a great example. We see that all the time, and a lot of it's related to sensory aspects. Some clothes simply aren't comfortable, so we want to take them off. Pulling, picking at dressings, devices, cords, oxygen tubing, hair, hoarding and stealing. Hoarding and stealing is usually an institutional or trauma-based aspect in presentation, so the interventions have to be quite different. Now, the importance of rec therapy and activities. Again, I can't stress enough how important it is to have certified therapeutic recreational specialists, those CTRSs, in your facility or well-trained activity staff. We can modulate and intervene with a lot of behaviors through the utilization of an activities department. Right. They can increase or improve, not increase, improve the symptoms of depression, adjustment difficulties, decrease levels of anxiety because of the positive engagement and structure, create social connections and community or a sense of community, increase strength, right? Like wheelchair yoga, sitting to be fit, those fun things. We see a shift in sundowning with an active activities program and boost cognition because there's engagement. What can we do further, though? I'm a huge proponent of music. Integrate music at every opportunity possible. It's a beautiful thing. It's a fun thing. And even if we move away from individuals who, let's say, have schizophrenia, let's talk Alzheimer's for a little bit. The last piece of the brain that breaks down and decompensate is the part of the brain that can process music when we're talking Alzheimer's. So music can create a sense of calm no matter what stage of the disease process a person is in when we're talking dementia. Right? Art therapy, creation, really any craft or art, just the creation and engagement. It's tactile, it's sensory based, it's fun. Movement, dance can go right back to music. Again, that exercise and gardening, pet therapy. And gardening doesn't have to be expansive, even though a lot of my homes here in Michigan, we do have raised beds, garden beds. And in the spring, people will be out there in their wheelchairs gardening. A great example is it doesn't have to go to that extent. One of my other homes has a plant club, and they have plants throughout the facility, and they keep and update binders that give descriptions of these plants, and they have a schedule of who waters what, where, but it gives them a purpose, and there's active engagement. Right? Then engage in life review, some storytelling. Now, before we move on, I would like to throw out the opportunity for questions before we jump into the last handful of slides here. There's going to be time at the end too. Does anybody have any questions currently? No? Well, we'll move forward. Some general non-farm strategies. We have to remind staff that not every intervention will work for every resident every time. We want to arm them with a tool bag full of interventions, and what works today may not work tomorrow, but it will work in 30 days. We have to stay flexible and we have to get creative. We have to remember that environment triggers a lot of behaviors, and the biggest piece of the environment is us as caregivers. And we can adjust on a dime. We can change our voice, our volume, the rate of speech, our body posture, our proximity to a patient. We can adjust a lot about ourselves that can really have a positive impact on behavioral presentations. And then the environment itself, again, we want to look around, see what's happening on the unit or location that a behavior presents itself. Document the heck out of it and create a plan. Some more specific interventions. Another way to see behavior is that it's an expression and communication of an unmet need. And then it's up to us to ferret out what's the need. Are they hungry or thirsty? Are there mobility issues that are causing frustration for them? Chronic pain or acute pain? Or are they just simply bored? When we're bored, we get mischievous. We stir things up to stimulate ourselves, right? Or is it an environmental trigger? Too much or not enough stimulation? Individuals, other residents, the lighting levels. Is there a roommate issue? And that one gets complex, especially if your census is pretty full. We can't just move people around, but it's important to be mindful of it. And there again, we get creative. How can we navigate it a little bit? And we do have to be mindful of the presence of sensory impairments, whether it's hearing loss or visual impairments. There is the loss of hearing. They may not hear us coming, and we may not, if we announce from down the hall, hear us introduce ourselves. So we want to approach from the front, get their attention, right? Whether it's a hand gesture or getting at eye level. There's a visual impairment. Our voice is our tool to allow an individual to hear us before we make it to them. And I'm a big proponent of orientation. And sometimes I will drive some of my younger patients crazy because I'll introduce myself every time as, hey, it's Michael, your therapist. I'm here for your session today. My younger ones look at me as though I have a third eye and say, I know, I saw you. We saw each other 2 weeks ago. I remember. But I do it every time because sometimes folks just don't remember. And when they can't remember, they'll get frustrated. Now, we want to be mindful of our pace when we're providing care. We don't want to hurry. We don't want to rush somebody. Take small breaks to allow a person to gain an aspect of composure, right, and calm within the interaction. And with that, we want to make sure that we break everything down, one-step processes. Right? And when we get through that step, we go to the next, and then we go to the next. Again, all of these things too that we're discussing can be used in the care plans as interventions. And then if they don't work, we shift, we change the care plan. Now, the general environmental strategies, environment's a huge piece. Stability and consistency are key. Individuals thrive, we thrive in consistency and stability. So we try to limit shifts in caregivers. Pretty hard to do right now, though. Reward caregivers that work well with residents. And again, they'll be challenged too. Now, videotape successful staff during difficult encounters to educate other staff. This can be done through role playing. Now, we don't do the videotapes anymore, it's all electronic, but create scenarios within the training. Integrate role playing within dementia training so that staff have to experience it and kind of fumble their way through. We'll see a lot of positive responses with doing that. Try to minimize room changes as much as possible. And the reason for this, I always understand why room changes occur, but several studies have shown that room changes themselves with an individual who is either struggling with an unstable mental health condition
Yeah.
or a progressing dementia, this will result in delirium. Changes in environment result in delirium, right? And then we don't know the time frame necessarily, but we're dealing with a change in mental status, which then could be highlighted on a BIMS. There's mood aspects to it. It can change the whole approach, but also could have been avoided on the front end of things. Structure breeds improvement. Again, it goes back to that structural component of we need the folks we serve to know what to expect from one day to the next. If we're throwing curveballs at them and changes in structure and changes in routines and schedules, they're going to be dysregulated all the time. And we will have increased behaviors. And we don't want to do that to the extent that we're starting to have the conversation of medication integration in those moments. Now, the addition of medications within the 4 weeks after change of environment is not likely to be helpful, right? But we do see it a lot, even for adjustment, the utilization of some medications, but the outcomes actually don't improve when it's studied and broken down. So try to control the amount of stimulation. Think about yourself or others that you know. Some of us respond exceptionally well to high stimulation environments. Others, when we're in a high stimulation environment, it burns us out. If you go out to a big event or if you go to a concert or if you're in a busy environment, some of us need a day or two just to find our balance again, right? Our patients are no different than that. We need to know who's the introvert and who's the extrovert, who responds well to big activities and who prefers one-on-ones. Now, the biggest piece here before we wrap up is document, document, document. Documentation paints the picture of the path and the narrative of our plan and process and what we've done. And I'm a strong proponent of the belief, I maintain this belief, I always have, that I believe our staff, we do the right thing, probably 99% of the time. Unfortunately, a lot of our staff have 50, 60, 70 things to do during their shift. And then at the end, they're trying to, again, document those 50, 60 or so things. And then the documentation lapses. and it just doesn't show what they've already done. So we might as well own what we're doing and what we've done within the environment. Now I'm going to open it up to questions and discussion.
Yes, if you've been muted, feel free to unmute your line and ask any questions that you have. Or if you're more comfortable doing so, type your question in the chat box. Don't see any questions, and that's okay.
Yeah, that's all right.
Are you comfortable, okay, with sending me a copy of your slide deck and we share that with the
Oh,
group?
use it. Yeah,
Okay,
absolutely. I'll get it over to you.
perfect.
Absolutely use it. Yep,
Great.
absolutely.
We'll
And,
include that with the recording.
yeah, yep. And if there's any additional questions that may come about, you feel free to reach out to us and we're happy to ferret this out with you guys and really problem solve it because I think this is going to be a stressful time for everybody because it's a new perception. And I think not only is it a new perception and approach, there's, as I mentioned in the beginning, there's a discretionary component to how surveyors can interpret this. And we want to try to cover all of our bases to eliminate their ability so that their own biases, I guess is the best way to put it, take over when they're reviewing some of these medications or the GDRs or even the behavioral health programs we're utilizing.
Yes. And also, just a reminder for anybody that is attending spring conference or maybe hasn't registered yet, the team from Behavioral Care Solutions will also be there. They're going to be presenting at
Mhm.
spring conference. So it's
Yes.
another good opportunity to engage, go to the session, learn some more information. And also, they're going to be at spring conference. So you can always ask them questions while you're there.
Yeah, I know I will be there, and I believe it's about 90 minutes. So I think we're going to
Yes.
dive even deeper into all of this stuff, both from the regulation standpoint, but also what can we do to maintain compliance, but also create positive outcomes for the folks we serve. So I'm happy not only to present it, but linger a little bit and have conversations with all of you.
Wonderful. Well, thank you so much, everybody, for joining us today. Thank you, Michael, for presenting. Again, we are going to share this recording. We'll include the slide deck from today and Tuesday. And I hope everybody has a wonderful day. Take care.
Thank you, everyone.
Bye.